University of Cincinnati Family Medicine residency and are both associate professors of family and community medicine at the University of Cincinnati. Dr. O'Day is the medical director of Crossroad Health Center and has been teaching global health, including leading trips to Honduras and Guatemala for more than a decade. Dr. Rich is the program director and has a special interest in curriculum design, specifically around the care of vulnerable populations. With that, I will kick it over to the presenters.
Thank you, Claire, for that lovely introduction. Let me pull up our slides here. Perfect. Well, as Claire said, I'm Dr. Megan Rich, and I'll get us started today. And then we have both Dr. O'Day here with us and Francisco de la Garza Iga, who has also been helping us with this project. Andrea Rosado is one of our residents who helped a lot with this project and was unable to join us live today. I think Claire covered this pretty well. So we'll start with just some background. I know I'm preaching to the choir when I am talking to the group of people who are watching this webinar, but when it really comes to making an impact on patient outcomes, addressing our social determinants of health, including the determinants that affect individual behaviors, really has a much bigger impact than all we do in clinical care. All those prescriptions that we write, all those procedures that we do, the referrals that we send really are dwarfed by the impact of social needs. So I think it really then is getting at this question, not only what makes a community healthy, but really we're talking about how do we train our future healthcare providers in a way that they can be health advocates and change agents and be promoting community health. For us in our residency program, which is a family medicine training program, we have a global health curriculum, which really has two arms. I think some people, when they hear the word global health, they think more international health. And for us, global health is really in reference to the whole globe, which of course includes where we are locally, right here in Cincinnati. And we have a variety of teaching methods, whether we're teaching about the international side of things or the domestic side of things. And so there are sometimes just assignments for self-directed learning. Lots of times there are workshops, and there's a lot of experiential learning that's happening on both sides. And I'm going to hand it over to Dr. O'Day.
Yeah, thanks so much for inviting me to participate in this. So I'll be just talking a little bit about our international partnership and how we've changed and morphed over the last couple months with the COVID pandemic. So our global health partnership that we have with an organization takes place in Guatemala. And Guatemala, just to kind of give you a short overview, it's actually an upper middle income country, and it's about the size of Ohio. And has about 16 million people. And at first glance, the indicators look pretty good. The health indicators, the life expectancy is about years. However, Guatemala actually has the second highest level of poverty in the Western Hemisphere after Haiti. And in particular, in rural communities, 8 out of 10 people live in poverty. And it has a very, very high rate of malnutrition, and almost half of the kids in the country are malnourished. Can you go to the next slide? Thank you. So just to give you kind of a sense of what the most important risk factors are that cause the burden of disease in Guatemala, as I mentioned, malnutrition is it's a really big deal. And so that is one of the risk factors that causes the most death and disability, including infant and childhood mortality. But diabetes is also a big deal, and that also affects the health of Guatemalans as well as alcohol and drug abuse. Those are really big issues as well. And so these are a lot of the things that we're kind of dealing with when we're seeing patients in Guatemala. You can go to the next slide. So I wanted to talk a little bit about the indigenous groups of people in Guatemala. And interestingly, Guatemala actually has the second largest proportion of indigenous populations in Latin America. Almost a half of people in Guatemala will identify as indigenous, whether that's Mayan or Garifuna or Chinca. Um, so the Unfortunately, they are disproportionately affected by poverty. So almost 80% of the indigenous in Guatemala live below the poverty line. And essentially every health indicator that you look at, the indigenous peoples will suffer a disproportionate burden. That includes life expectancy, maternal mortality, infant and child mortality, as well as malnutrition and stunting. So they really suffer quite a bit in Guatemala. Can go to the next slide. So we wanted to talk a little bit about some of the determinants of health that we address and encounter in Guatemala. And so language is actually a really important one. There are actually over 28 languages spoken in Guatemala. This slide actually should say 21 official Mayan languages with over 50 dialects spoken. And a newcomer might feel and think that maybe folks can understand each other if they speak different indigenous languages, and that's actually not true. A lot of Mayan languages are not mutually intelligible, so they may not be able to communicate with each other if they're from speak different indigenous languages. And this affects health in a lot of ways. And in particular, it affects the health of people when they're seeking health care. So for the most part, in government clinics and hospital clinics and private clinics and the places where people seek health care, the Mayan languages are actually not spoken. And so people may rely on their child to function as an interpreter, or they may just try to muddle through without an interpreter. A lot of our patients may speak what we call market Spanish. So they have enough Spanish to kind of buy and sell things in the market, but clearly not enough to be able to explain their physical problems. So we know, and for sure, that the use of professional interpreters is associated with decreased health disparities, better patient comprehension, fewer errors, and better satisfaction on the part of both patients and providers. So we know language is an important determinant of health. Can go to the next one. The next determinant of health that's really important to our work is culture. Because culture really frames how we think about health and illness in general. It frames how we view health, what we think causes health and illness in our community, maybe what diseases are stigmatized or looked down upon, how we express pain, where and how we might seek health care, and if we're going to adhere to recommendations from the healthcare community. So culture is just an overarching important determinant of health. And we find this as a really important component to our work in Guatemala. Can go on to the next slide. Thank you. Access to care is also a huge determinant that we address and think about in Guatemala. In Guatemala, the farther away from the cities one gets, the harder and harder it is to access healthcare. That's just kind of an example of some of the roads, which are very challenging to travel on, not only in a truck, but often on foot. So the farther one gets away from towns and cities, the fewer and fewer providers there are. While there are health posts in the rural areas, they are often not staffed. They might be staffed by a provider maybe once or twice a week. They have few medicines and supplies. And certainly the farther out you get, clean water and sanitation, even in the health posts, is really challenging to find. So access to care is a really important determinant that we think about in Guatemala. And we see that the rural people who live in rural areas also have poor health indicators. So the organization that we work with is called Maya Health Alliance, and they're an amazing organization that we really love working with. Their goal is to improve the health of Indigenous communities by providing culturally competent care in the patient's preferred language. And so they work across the states in Guatemala. They work in communities where they're asked to work and welcome to work. They're a medium-sized organization serving about 20,000 patients each year, and they are a overwhelmingly Guatemalan and Indigenous organization. So the majority of our staff are female Indigenous staff members. So if I think we can go to the next slide. They do provide care in over 6 Mayan languages as well as Spanish. And they really focus a lot on chronic and acute medical care over the lifespan. And they provide a lot of services, in particular addressing maternal child health. So they have a child malnutrition program. They do a lot with healthy moms and babes and prenatal care, healthy deliveries, as well as contraception and family planning. So just a little bit about our program. Back in 1990, our global health program was founded when Shoulder to Shoulder was founded, which is an organization that was founded by our department in association with a community in rural Honduras. And Shoulder to Shoulder was founded on the ideals of empowering communities through a partnership with academic institutions and also addressing the social determinants of health, utilizing principles of COPC, or community-oriented primary care. They also emphasized a sustained commitment through this partnership with academic institutions, which allowed them to leverage resources to benefit the communities. Unfortunately, in 2009, there was a coup in Honduras, and the security situation in Honduras kind of worsened, and we didn't feel like it was safe to continue sending groups. And so in 2011, we made the hard decision to kind of move away from our partnership with Honduras, and we looked for another organization that we could partner with. And over the course of a couple of years, we were able to connect with Wukukuwalk, or Maya Health Alliance in Guatemala. And now we've been partnered with them for the last 6 years. And that's a picture of our first trip 6 years ago. I think we can go to the next slide. So our partnership is really a commitment to continuity of care. So initially we were visiting and working in Guatemala twice a year, and our partner said to us, "We love having you, but twice a year isn't enough. We need to see you more often." And so we very quickly moved to a model where we send groups of learners and attendings 4 times per year, every February, April, July, and November. And so kind of the goals are continuity and a long-term commitment. We do this with a shared electronic medical record that's web-based. All those entries are in Spanish so that all of our partners can read that. We have a consistent formulary, and most of our residents many of our residents go 3 times. All of our residents will go at least once for the most part. And because of this, the residents who go 3 times and have some interaction with the organization and the patients on the ground, they're able to count those patients towards their continuity numbers. So this is just kind of a little graphic so you can see the timeline of what's been happening with our trips in general over the last 2 years. So again, we usually go 4 times a year from July, November, February, and April. The last time we went physically was back in February of 2020. And as you remember, when the pandemic hit in March of, well, for many of us in March of 2020, we thought it might be kind of short and over quickly. And so we canceled that trip. But very quickly we realized this was not going away anytime soon. And so we were able to work with our partners to kind of flex and morph into telehealth. And so all of the 2020 to 2021 quote trips have been flexed and have been telehealth trips. So I'll tell you a little bit about how we were able to do that. If you want to go to the next slide. There were a number of steps that we took to try to move to a telehealth model. The first one was just, our continued frequent communication with our partners on the ground, and just talking with them and communicating regularly during COVID and when it was hitting, and trying to figure out how we could best support them from afar. They were starting to do telehealth themselves with their nurses and community health workers on the ground. So when we proposed telehealth in April of 2020, they were really open and excited about it. So our next step was to figure out how we could do that. And like everything else, we thought Zoom might work. And so we utilized both Zoom and another app, WhatsApp, in order to communicate with the staff and the patients on the ground. We utilized the community health workers from Wukukuwak and the nurses to make appointments for patients during our regularly scheduled visits. And they did this in our usual villages. So we always go to the same villages every 3 months. And so they chose those villages and were able to make appointments for patients. We utilized all of our usual protocols, such as how to manage patients with diabetes and things like that. But then we also developed extra protocols for how to manage telehealth. We were fortunate to have a large supply of medications and other equipment already down there that we were able to use. And then Wukukuwak supplemented all of that with a formulary of medications. And then Wukukuwak was able to continue to contract language interpreters for us. And so over the course of the year, we developed precepting protocols. We were continuously just watching to see what the issues and problems were and barriers, and kind of coming up with solutions to those with our partners on the ground in Guatemala. So we can go to the next slide. So our framework is that we have patients in Guatemala that we are already depending on us for their care. We have a great group of residents and learners here in our residency. And really the thing that connects us is the community health workers and the nurses who have that frequent contact with the patients, and were able to help us with technology to connect us. So if you're wondering how a telehealth visit looks, this is kind of a schematic of what happens through a visit. So as I mentioned, the nurses and the community health workers on the ground schedule the appointments. We do have a database that includes follow-up. So if we've seen somebody previously and we want them to follow up, we enter them into a database. So they use that, as well as patients who are seeking care, to make a schedule of appointments. And then they share that with us before our clinic days. And then the patients, as they came in, they were seen at the usual clinics where we would ordinarily see patients. They were checked in by the Wuku Kuok staff and nurses. They had their vitals taken. The nurses would let us know through the EMR that the patient was there and go ahead and put their vitals in. And then our residents would get the Zoom going, and the nurse would set the patient in front of the Zoom. And then the resident would go ahead and begin the visit. Some of our residents speak Spanish and some of the patients speak Spanish. And in that case, no language interpreter was needed. However, oftentimes that wasn't the case. And so the language interpreters were on the ground in Guatemala. We also found it was super helpful to have staff on our end in Cincinnati available for interpretation. And so, for example, Francisco, who's on the webinar, was one of those people, and we used some of our medical Spanish students as well to help out with that. So after the resident saw the patient, they would keep the Zoom going. They'd step out and precept, and then they would come back and kind of give the plan to the patient and enter that plan into the EMR so that the nurse could go ahead and fill the medications and give the medications to the patient. Any other extra communication was done via WhatsApp, which is a super common form of communication across the world. Yeah, so it allowed us to use some great technologies in terms of sharing our screen with Zoom. So the residents were able to pull up videos in Spanish about, for example, how to use an inhaler or what exercises would be helpful for their back pain or whatever issue they were struggling with. So the residents came up with some great ideas for share your screen. You can go to the next slide. So just thinking through how we address language and culture as determinants, these are some of the things that we do and that our residents learn. So first of all, language is super important and is always assessed, and we always provide services in the patient's preferred language. The interpreters are incredible on the ground. They speak English and Spanish and the indigenous language, either Cachiquel or Quiche, and so they can interpret directly from, say, Cachiquel to English, which is really helpful. All of our learners also complete modules before they go based on related to working with an interpreter. So they watch some videos and do some role plays about how to best work with an interpreter. And then, as I mentioned, we found it super helpful to have interpreters on both sides. The interpreters in Guatemala function also as kind of cultural brokers, and we have a really great relationship with them so that when there's cultural issues that come up, they can really help us navigate those, which does bring us to culture as a determinant and how we address that. So preparation for our learners is really important, and for our attendings, I would say. So the attendings that also go through a pretty intense preparation before they go, and that includes quite a bit of information about Guatemalan culture and history, so that they have background before they walk in the door, before they fly to Guatemala. We also do some modules on cross-cultural encounters, which really helps give kind of a framework to the learners about how to kind of navigate these encounters, which obviously are not just important in Guatemala, but everywhere, right? So they get a chance to both do some role plays and then really learn about some really common culture-bound syndromes that we see in Guatemala and oftentimes throughout Latin America, like evil eye or susto or nervioso. We talk about those a lot and how to kind of work through those as well. So we can go to the next one. I would say probably one of the most important things that we do in terms of addressing language and culture is to just work with this really amazing organization, Wuku Kuok, that also puts that as a priority and recognizing that language and culture are determinants and that having staff who are part of the culture is incredibly important. And so we just have a really wonderful partnership with the staff who we rely on and recognize as the experts that they are. And so we're continuously consulting them and working with them and learning from them. So we feel really blessed to have a great relationship with them. And then access to care, how do we address that? Well, when we are going there, we're physically not waiting in town for patients to walk 2 to 3 hours to us, but we're driving over these rough roads to get to the patients. So we're seeing patients where they live. You can kind of see some of the villages where we do go. And so that addresses access to care. And then obviously now it's great that we can kind of provide care through telehealth as well. And so that certainly addresses access to care as well. So we talked a little bit about this, but our preparation and orientation is really important. So we talk a lot about our partner organizations, how to treat common problems, as well as the Guatemalan health system and ethics. And then our residents who are our interns who are going through orientation right now also have training in telehealth as well about how to work with a healthcare team, how to utilize a healthcare team, and utilizing the technology related to telehealth. We can go to the next slide. So their telehealth orientation includes a session, a 1-hour session, and then they're watching faculty who are doing telehealth, and then they have an observed telehealth session before they can go and start doing them more independently. So I think I'll turn it back to Megan now to talk a little bit about some of our data in Francisco.
Yeah, we'll be going through 2 sets of data. So Francisco will start us off by talking about the patient-related data.
Yeah, hello, thank you. So as we can see, the first 2 columns, those 2 represent our in-person trips in which we were able to provide service to about 528 patients. The other 4 columns, July through April, are regarding the telehealth we provided post the beginning of the pandemic. It's important to mention that the distribution of service that we provide is really evenly. However, on the second in-person trip, we're able to observe a higher number of service provided to patients in Guatemala. And we believe that the reason why this happened was the fact that we mostly took upper class band residents, and thus they might have been able to provide a more efficient and quicker service, and thus we're able to provide service to more people. Next slide, please. And then as we can see, the distribution, the age distribution across the both types of trips, the in-person trips and the telehealth trips, we can see that the age distribution is pretty similar across the ages, with the most number of patients seen in the age gap between 15 and 45 years of age. Next slide, please. And in here, we were able to see that in both in-person and telehealth trips, we can see that we have about the same diagnosis provided. However, percentages are a little bit higher in the telehealth services that we provided. The reason why this might be happening is the fact that residents are providing services from their curriculum in a in Price Hospital with AC, and thus we believe that maybe some environmental factors might lead them to provide a more complete and accurate checkup, while when you are in an in-person trip, you're probably dealing with some culture shock and some of these things that might decrease your efficiency and efficacy.
All right. Well, I'm going to talk a little bit about the learner outcomes because there's, I think, an important question here of how are we training residents and what are those learning outcomes when we compare in-person to telehealth. And so we decided to use an evaluation form that we've been using for a number of years, probably close to 5 years. And so in that evaluation form, the residents are both rated by the faculty preceptors on the trip. They're rated in 2 different ways. One on various skill sets related to the social determinants of health and specific to global health. And 2, they are given an overall level of independence for the trip. With a 1 meaning, this was a resident that really needed me for every step of the patient visit. I was, helping them gather data. I was helping them come up with the diagnosis and the plan, compared to a level 5, which would be somebody who is really functioning at an independent level, and teaching is all around the art of medicine and the art of global health. So here's our data. So we started with data from the 2018 to 19 academic year. So it runs July to June. This was long before anyone was thinking about a pandemic. And so you can see in blue, in the dark blue, those are residents who are on their first trip. So that's basically, those are interns. And then we have residents who are on their second trip that year. So our second year residents. And you can see there's a difference in levels of independence, as you would expect. And then when we look in, this includes the 3 trips, not the April trip that was canceled, but the 3 trips leading up to the pandemic in the following academic year. Kind of similar spectrum, a similar jump between first and second year and level of independence. And then we have our data from our 4 trips in this current academic year. And again, we'll talk a little bit more about these differences, but again, a nice big jump between first and second year. So when we're looking at the in-person trips, going from having, this is the same cohort, right? So they had their first in-person trip in 2018 or 19, their second in-person trip in 2020. You can see they had this nice jump in their level of independence. Our second cohort that we were following had their first trip as interns in the academic year of 19 to 20. And then this past year, they had their second trip, which was a telehealth-based trip. Either way, they still had a nice jump in their level of independence as second years. And overall, there's not a lot of difference in these levels of independence. If we're looking just at those first trips, those who were on a first trip here in 2018-19 have about the same level of independence in 19 as those who had the first trip in 1920. But there is a little bit of a difference here in that virtual trip. That overall level of independence for interns this past year was a little bit lower. Our N isn't very big, so we don't know about statistical significance at this point in time, but hopefully as we gain more data, we'll be able to answer that question. So looking then at the second part of the evaluation, so that was just the global level of independence. We also looked at the individual skills that were assessed when it came to addressing social needs. And so those were things like being able to apply global health principles. So those would be principles like social justice, solidarity, humility, especially when you're on a short-term trip. They were things around cultural humility. So that one's about a cross-cultural encounter to address culture in the history and in the assessment and plan. How effective were residents in utilizing their interpreters? How were residents, how effective were they at identifying undernutrition in their patients? As that was, as already mentioned by Dr. O'Day, it's a big problem when we go to Guatemala. And then being able to utilize community resources local to Guatemala. The last one being, can a resident identify and effectively communicate with patients who have a lower health literacy proficiency? So as we're looking at this data, this is a first trip being in person. So in the prior academic year, but pre-COVID is in blue, post-COVID is in green. So just people who did the telehealth version of trips. And so we can see there's really only one area that there's a gap. And again, I don't have numbers on statistical significance just yet, but there's about a 1 point difference there. Otherwise, most skill sets, residents are performing about the same. When we look at those who are on their second trip, either the year before the pandemic or this past year in the virtual trips, there's not a lot of difference in our second year residents. They're getting roughly the same rating, whether they did their second trip in person or through telehealth. The other thing we looked at was just how many times did the faculty complete this part of the evaluation? The overall level of independence is a required field on the online evaluation of the resident. But these other skill sets, these individual skill sets are an optional field. So you don't have to fill them out. And so you can see that when it's an in-person trip in blue, we definitely had a few more, faculty filled out these fields more often. So, for at least these three, the principles of global health, the cultural humility, and the undernutrition, those were filled out less frequently. We don't actually know why at this point in time. Is it that the faculty had less opportunity to observe, or residents had a less opportunity to demonstrate over a telehealth visit? Another thought is that while, as Francisco mentioned, for residents, doing telehealth in person means that some distractors are not there, right? They're not feeling overheated. They're not dealing with a diarrheal illness or adapting to culture. For faculty, the opposite does seem to be true. Faculty for an in-person trip had far fewer distractors than a virtual trip. We just don't tend not to cancel things. You can still, work meetings in around your precepting sessions. And so were faculty then just being a little bit briefer in their evaluations because they were pulled in so many different directions. We did ask the residents to evaluate the trip. And actually we also had medical students on some of the later trips. And we asked faculty to evaluate. So everybody completed an evaluation form about the trip. And so for the telehealth trips, everyone was satisfied to very satisfied, and no one reported feeling neutral, unsatisfied, or very unsatisfied. And the vast majority of people said they would definitely recommend the telehealth trip to a friend, with only one person saying, well, maybe. Nobody said no. We had some open-ended questions, and we did a very brief, informal, qualitative analysis of that, just to try and get an idea of what kinds of themes people were coming up with. And then we separated them out based on who was writing about them. So you can see that for residents and med students, man, just being able to have the opportunity to participate in patient care, that was the best part of the trip. They didn't think they were going to get a trip this year. They did. They got to see their Guatemalan patients. So that was really a highlight for them. Everyone kind of equally really loved working with members of our international healthcare team. Faculty were the only ones who cared about saving on time and travel and the headaches of that. With an eye towards improvement, the residents and med students mostly commented about improving the training for the healthcare team. Faculty and med students talked more about just doing that QI work that Christy mentioned, constantly reevaluating our processes, making sure everyone's trained on the latest. And faculty were the only ones who really had kind of that eye towards the future of, well, are we making sure our patients have opportunities to be followed up in person? Are there ways to acquire more resources for these visits? And the most challenging part some people mentioned internet connection, although I think the prompt actually asked them, besides the internet connection, what else would you like to see improved? Residents talked mostly about finding better ways to use interpreters. Faculty were more worried about the virtual limitations of a virtual exam or not having enough resources. And med students wrote about a variety of things. We have some informal feedback from our partners in Guatemala, who, again, I think we're very appreciative that during this time of adversity that we were able to find a way to come through. Again, we don't want to do away with in-person trips completely, but this was a really unique opportunity. We did have some challenges just around internet stability, especially when weather was windy or bad in Guatemala. There are time zone differences that needed to be taken into account when scheduling patients. And at times during the pandemic, there were curfews in Guatemala, which again, this needed to be taken into account when making appointments for patients. Residents mentioned that they felt like sometimes it was harder to connect over virtual visits. I'm not sure that that's specific to Guatemala. I've heard them say the same thing about local telehealth visits. And then just making sure that we had enough support staff. It is kind of a heavy lift for the staff to pull it off each visit. There were a lot of visits. I think there's great teaching for the residents in telehealth and learning how to do some of those virtual exam, how to navigate that. Residents did feel like they could better focus on the patient care because there were less distractors. I think everyone was very relieved to be able to come through for our patients and to not delay trips for a year or more. The nurses were really great and very effective in their roles, and both patient and resident satisfaction was high. There's, of course, a few limits to our study of our outcomes. Certainly in resident assessments, there is a high inter-rater variability. I'm the program director, so I get to see the evaluations for all rotations, and I definitely know who my more lenient graders are and who my more strict graders are within the residency. So just depending on, who was precepting an in-person versus a telehealth visit could have skewed some of those results. It's still a pretty small sample size at this point in time and underpowered to really get to statistical significance. We still haven't answered a lot of questions. For this upcoming year, we are looking forward to returning to Guatemala in person starting in November. Actually, Dr. O'Day will be going down in July. Residents will return starting in November. So we'll have 3 resident trips this year. And it will be interesting because our rising second years, who will be leaders within those trips, will have only done. So we'll see how their levels of independence change and what we can glean from that. And of course, we are not able to draw any firm conclusions about what's the right dosing of in-person trips and telehealth patient care to maintain continuity and to provide excellent patient care to our patients in Guatemala. I'll hand it back to Christy.
So what did we learn from this experience? Well, as kind of has been mentioned a couple times, I think this is actually a great introduction to global health work because it does really allow our learners to just focus on the patient in front of them and to be less distracted by maybe the heat because it's 100 degrees or the illness they might feel or the animals that are running around them. I think that in your climate controlled office at Christ Hospital, you can really focus on the patient and some learning issues better. So I think that this was an unexpected benefit, but we definitely saw that. We definitely learned that it's important to have interpreters on both ends. And we learned it takes time to do telehealth and do it well. And so it may actually take longer because of issues related to internet, related to interpretation, and just maybe needing some extra time to connect with the patient that you might not need when you're in person, but you need that by telehealth. For the staff on the ground, they found that they needed about 3 staff in Guatemala for 2 residents because they need someone to check in and to kind of assist with during appointments and then often afterward to dispense medication. So it's a lot of hands-on work for them on the ground. We found that it was extremely helpful if at least one of the dyad, the resident or the preceptor, had been to Guatemala and had practiced in Guatemala. And ideally, for sure, the preceptor if the resident hadn't. Those were some of the lessons that we learned. We can go to the next slide and talk about some next steps. So we're really excited because we have started kind of developing a continuity clinic for some of the residents who are piloting a longitudinal continuity clinic with patients in Guatemala in between trips. So they're doing that 1 to 2 times a month, seeing some patients in between the trips. So we're kind of figuring out how to do that over time. Megan mentioned that I'll be going next month. And one of the things we learned is how helpful it would be to teach some of the health workers down in Guatemala some basic skills like how to dip a urine, how to look in a year, how to check a hematocrit. So we'll be doing some of those things over the next year so that they can really supplement the telehealth much better. And we'll continue to evaluate our services and evaluate the quality of care that we provide. So we're already kind of doing that in person. So now the next step is to see how we're doing that through telehealth. We're also really excited about this project, which is another way to address the social determinants of health. As we said before, malnutrition is a huge issue, and that is really related to the lack of clean water. And so we received a grant to evaluate patient preference between 2 different types of water filters so that when patients come in and we identify that a child has either malnutrition or diarrhea, we'll be able to actually write a prescription for a water filter, and then they'll be randomized to one of 2 different filters so that we can see which one makes the most sense for their environment. So we're really excited about that project. That'll be done in person next year. And we just want to thank everybody who's been involved, our amazing staff in Guatemala who've just done an amazing job putting this into place for us. We have a great group of preceptors that we couldn't have done it without them. And then we have some residents who really piloted this and were our guinea pigs in the beginning. And it was super wonderful working with them. And thank you to all of you for NCAS for hosting us and to Claire for all your help. So thank you.
Thank you. It was a great presentation. I really appreciate it. Are there any other final thoughts before we conclude?
I don't think so.
Great. So we will have this video posted maybe by the end of the day, otherwise by the end of the week or early next week.
Great. Thank you so much.
Thank you so much. I really appreciate it, everyone.
All right. You guys have a wonderful day.
You too. Enjoy your
Thank you. See you
orientation.
all.
Bye-bye. Thank you.
Bye.
Bye.